All right, Dr. Ryan, I think we can get started.
Sure.
We might have some stragglers, but good morning, everybody. My name is Susan Lautenbach. I'm with SK Life Science. I'm also a volunteer with Epilepsy Awareness Day at Disneyland. It is my greatest pleasure to introduce to you Dr. Arain. He's professor of neurology and chief of epilepsy division at the University of Utah in Salt Lake City. So thank you so much, Dr. Arain, for spending your morning with us. And I will be monitoring the chat. So if anybody has any questions, I will monitor the chat, and as we go along, either answer them or towards the end, depending on how Dr. Ryan would like to do this. So we want this to be interactive. So thank you so much for joining us this morning. And Dr. Ryan, it's all yours.
Thank you, Susan. Thank you to all the organizers who have invited me to talk. I'll discuss about epilepsy in elderly. When we think about epilepsy in elderly, people usually think it's a rare condition and usually caused by brain tumors or so. But we will discuss all these, and it's not a rare condition, and brain tumors are overrated. Usually it's caused by cerebrovascular accidents, and demographics of seizures, semiology is very different than younger patients. Often it is misdiagnosed. Let me share a case with you. A 75-year-old male had his first generalized tonic-clonic seizure 4 days post-abdominal surgery. And when his EEG was done, it showed generalized polyspike activity. That's indicative of a generalized epilepsy, but he had never had any seizures before. But on questioning, it seems like he was having some staring episodes in his teenage years, but was never diagnosed. So it can happen that the generalized tonic-clonic seizure may appear in elderly while they were missed. Having a de novo generalized epilepsy is also possible, but there are rare reports of these. And usually that's because of arrangements of stopping benzodiazepines, and in that situation it can come on. So epilepsy, like other illnesses, chronic illnesses, can have onset in younger age and can continue as the person gets older. So it can continue into the old age. However, the seizures do change with increasing age, and typically it has been seen that the seizures become briefer and milder and with fewer clinical features, and about 84% of them showed remission of generalized tonic-clonic seizures. So it tends to show remission of generalized tonic-clonic seizures, and they become more focal impaired awareness seizures or focal aware seizures. There are also reports of reemergence of seizures in patients with idiopathic generalized epilepsy, as I showed you an example of a 75-year-old gentleman. Let's review another case. A 70-year-old man presents following a witnessed generalized tonic-clonic seizure that seemed to start with a right arm shaking. He has atrial fibrillation and takes digoxin. His exam reveals a mild right hemiparesis, so he was having some Todd's paralysis. He was also on anticoagulation. His family had some questions. Isn't it unusual to have seizures at this age? What caused the seizure, and is medications necessary, and will he have another seizure? So certainly it's not a rare condition. Previously we used to think that the seizure is a condition of younger patients. And as you can see in the graph, there are two peaks, one in the first 2 decades, and then immediately after age 60, there's a sharp increase in the incidence of epilepsy. And this data is from Rochester. This is from 1935 to 1984. More recent data was published in Lancet from Iceland from 1995 to 1999, which is a pure Caucasian population, and it pretty much mimics the same graph as 2 peaks in the first 2 decades and then right after age 60. So incidence of epilepsy in elderly rises sharply after age 60. So at age 50, the incidence is about 28 per 100,000. At age 60, it's about 40 per 100,000. And then at age 75, it is 139 per 100,000. As a matter of fact, the incidence of epilepsy is higher than the incidence of Alzheimer's. So it's not a rare condition. Moreover, the epilepsy in elderly, the incidence and the etiology is very different. Semiology-wise, it tends to have a major chunk of focal impaired awareness seizure, or previously called complex partial seizures, and generalized tonic-clonic seizures are about 27%. That is lower than younger adults, and that at times pose a diagnostic dilemma. Looking at the etiology, vascular cause is a significant cause in elderly, about 32%. Semiological differences in elderly and younger adults. Auras or focal aware seizures are less common in elderly. Automatisms are less common. The seizures are more subtle. Motor features are infrequent. Semiology of focal impaired awareness are simple and shorter. And subtle episodes of transient confusion are more frequent in elderly compared to younger adults. One thing that also is interesting to differentiate between the younger adults and elderly is the postictal phase. And postictal phase in the younger adult can be 5 to 15 minutes, but in elderly, it can go on for hours and days, and that can be sometimes confused as encephalopathy. So as I said, the epilepsy seizure types in elderly is more focal impaired awareness seizure, or previously called complex partial seizure, and less generalized tonic-clonic seizure. Concomitant illnesses are quite common in elderly who have epilepsy, like hypertension, stroke, cardiac diseases are quite common, and they are on a slew of medications because of these illnesses. Imaging, MRI, is usually abnormal. It can pick up cerebrovascular accident, small vessel disease, or atrophy. On the other hand, the EEG can be normal in about 31%. And if you find abnormal features in the EEG, and those are usually not epileptiform activity. So what are the risk factors for epilepsy in elderly? Cerebrovascular disease, as I mentioned, neurodegenerative disorders like dementia, major depression, hypertension, and sleep apnea. So let's review these. Stroke as a cause of epilepsy. The incidence of stroke annually is about 750,000 in US. This is from 1996. Seizures after stroke cooperative study. This was from Bladen. This was a prospective 9-month follow-up. About 2,000 patients, about 9% of them developed seizures, and about 2.3% of them had recurrent seizures, meaning they developed epilepsy. Looking at what kind of stroke caused seizures, having a larger stroke, cortical stroke, hemorrhagic stroke with bleeding in the brain was more likely to cause seizures compared to smaller strokes or subcortical stroke. But there are also reports of subcortical cerebrovascular incidents causing seizures as well. The seizures that happen after stroke usually present within the first year or so, after 2 weeks to 1 year, but it can present as late as more than 2 years. Again, as I said, the stroke types, if you have a cortical infarct, that is more likely to have seizures. Lacunar infarcts can sometimes cause seizures too, but primarily it's the cortical large vessel disease that causes seizures. Looking at dementia or the neurodegenerative disorders, patients who have Alzheimer's, in an autopsy verified study, about 81 patients, 10% had seizures, and they were 10 times higher likelihood of having seizures than control. Seizures could occur at any stage of the disease, an early dementia or late or more severe dementia. It can present at any stage of the disease. And as is true for general seizures in epilepsy, focal impaired awareness seizures are more likely than generalized tonic-clonic seizure. Dementia and adult onset unprovoked seizure, a case control study of 145 patients, unprovoked first seizure after age 55. Prior Alzheimer's disease increased the risk of epilepsy about 6 times, and if you have other type of dementia, the risk is 8-fold to develop epilepsy or develop seizures. and median 3.3 years lapsed between the onset of Alzheimer's disease and the seizure onset by a study from Heisdorfer. So dementia does predispose you to have seizures, and when you're treating dementia, we should also keep in mind that donepezil, which is one of the anti-dementia medicine, can lower seizure threshold and can worsen seizures. In a study, in 18 patients, 2 had worsening of seizures just by adding donepezil. Major depression is also a risk factor for epilepsy, and this relationship between depression and epilepsy is bidirectional. So major depression is a risk factor as well for unprovoked seizures in elderly. And maybe it's the common antecedent that is at play with depression and epilepsy. Major depression alone is associated with increased risk of seizures, 6-fold increased risk of unprovoked seizures in age 55 or older. We talked about hypertension is also an independent risk factor for new onset seizures in adults, as well as and more so in elderly. In a case control study of 227 patients admitted for first seizure, mean age was 8 years, and then hypertension increased the risk of having seizures by 1.5 times compared to hypertension and stroke. If the hypertension and stroke were together, the risk of having seizures was about 4 times. Population-based case control study showed severe and uncontrolled hypertension increased risk for new onset seizures in age 55 and above. Here, diuretics were found to have a protective effect. Patients who have left ventricular hypertrophy, they were more likely to have epilepsy, but if diuretics were added, there was no increased risk of developing epilepsy. Sleep apnea can be a factor in de novo seizures or worsening of seizures in older patients. There's a study by Chihorek. Polysomnography data was compared in patients who were 50 or older with new onset or worsening of seizures versus stable or seizure-free patients. And they noticed that patients who were having worsening of seizures or they presented with new onset of seizures, their apnea-hypopnea index was 23 compared to control that was only 3.1. And this was statistically significant. In another interesting study, it was noticed that treatment of sleep apnea in epilepsy has shown to reduce interictal discharges as well as seizure frequency. So having treatment of sleep apnea has a positive effect on the frequency of epilepsy. Another point about epilepsy in elderly is that it is often misdiagnosed. And let me share a case with you. A 65-year-old female is brought by a family because of episodes of confusion where there are days she's confused and not able to perform her daily activity. So let me share this. She's laying here. She suddenly starts to stare and has some lip smacking. She was not tested during this, but if you notice that she has a dystonic posture on the right hand, so the ictal onset was in the left temporal area, but overall, very subtle seizure, not major semiologic features. Okay. Let's compare it with another patient, 67-year-old male, presents with daily spells of strange smell, then a hot feeling with nausea, and then he loses awareness. His wife reported some lip smacking. Occasionally he has fallen and has injured himself. He was put on Tegretol, but it increased his spells. So let's see his seizure, his episode. So here he has a few multifocal twitches, and then eyes are rolled back. His daughter, sitting by the bedside, realizes that he's having a spell and frantically tries to get attention by pressing the event button. few twitches on the face. So he was able to read the sign correctly. So if you compare the two videos, both of them have subtle features. Both of them had a few features that suggest that these are epileptic. But in this patient, when we looked at the EEG, it showed a syncope, basically. And here you have the eye blinks and then slowing, and then there is a complete attenuation of the EEG, and then it recovers back. So I've compressed it on this EEG, and you can see that there is an EKG asystole because of a cardiogenic function abnormality. So when we open it up, and you can see that he has a nice posterior dominant rhythm, and then became theta activity all over, and then becomes generalized delta, and then attenuation. And the reversal happens with the same thing, initially attenuation, and then the delta happens, and then theta activity, and then the posterior background recovers. And as this, you can see that the recovery from asystole is happening, EEG is improving. So this is the electrographic signature of a syncope. So this was not a seizure, even though it looked like a seizure compared to the other patient. But she had a left temporal seizure, and this one is just a cardiogenic syncope, but it looked very similar. There was a VA cooperative study, and in a subset, they looked at 167 patients. It took about 9 months to seek medical attention for the episodes or seizures, and about 1.7 years to get to the correct diagnosis. So often, seizures in elderly are misdiagnosed, or diagnosis is delayed. The reason is, again, as I said, and they don't present with generalized tonic-clonic seizure. They present more with focal impaired awareness seizure and less dramatic seizures, which are often ignored. And since they have a slew of other concomitant illnesses, so people think that they may be causing these episodes like TIA or syncope, or the medication side effects sometimes is considered, and people don't consider that epilepsy could be at play here. So again, the elderly compared to younger patients, the diagnosis of epilepsy, there's a higher percentage of partial focal seizures, focal impaired awareness seizures, more extratemporal onset seizures than classic mesial temporal onset seizures, more prominent post-ictal symptoms that can last several hours to a day. So that tend to make clinicians confuse about TIAs or stroke. Usually the patients are weaker historians, and also EEG is very less helpful, and there are more concomitant illnesses. These all add up to result in a delay or misdiagnosis of epilepsy in elderly. But once we diagnose someone with epilepsy in elderly, then we should treat. In younger adults, the risk of recurrence of seizures after first unprovoked seizure is about 30 to 35%. And when you have had 2 seizures, the risk of having a third seizure is about 70 or higher. In elderly, however, even after the first unprovoked seizure, the risk of recurrence is about 80%. So we tend to have a lower threshold in starting them on seizure medications because there's a high risk of recurrence. But whenever we decide to start them on seizure medicine, we need to keep in mind about the pharmacodynamics in elderly and pharmacokinetics and drug interactions as their body dynamics have changed. And here, I just want to remind everyone that majority of patients who are started on seizure medicines are not started by neurologists. Mostly it's ER physicians or primary care providers. And they usually start them on medicines that they're comfortable with. And it's still, in this day and age, some patients are still started on Dilantin and Tegretol and phenobarbital. If you look at this interesting study by Gillum, looking at the quality of life of these patients with epilepsy, if they're seizure-free, then the quality of life is good. If they're having one seizure or 100 seizures a day, the quality of life is not dependent on the seizure frequency. Rather, it is correlated with side effects. So patients would like to stay on a medicine that is tolerable. If they're having side effects, then that certainly affects their quality of life. If you look at the uh, pharmacokinetics of the older medications, phenytoin, carbamazepine, valproic acid, phenobarbital, primidone, ethosuximide, and clozapine, majority of them were highly protein bound. They went through P450 system. Some of them also had autoinduction, so they had a higher potential for interactions and affecting their medications. So medication use is greatest in older age. Older AEDs are frequently prescribed to elderly. There was a study from VA where from 1998 to 2004, still patients were prescribed dilantin and phenobarbital. AED efficacy and safety profile is quite different from younger patients. Pharmacokinetic changes happen with age, and we should keep that in mind. And there is a greater risk of drug interactions. This was a study looking into elderly patients who are in nursing home, and they noticed that patients, if they were on AEDs, they were on at least 6 medication, and majority of these medications are psychoactive medicines that can interact with seizure medications, or seizure medications can have interaction with these medicines, and that can affect their quality of life. So elderly patients appear to be more responsive to AED therapy at lower concentrations. However, they are also more likely to have side effects as well. And if you look at the physiological changes of aging affecting AED pharmacokinetics, there is change in the eye anatomy, a variable absorption. Serum albumin is low usually, so that alters the protein binding, and medications that are highly protein bound like phenytoin or valproic acid can be available in the serum as unbound or active medication. That can result in side effects. There's a decreased hepatic blood flow, decreased liver mass. Similarly, glomerular filtration is low. So not only that the metabolism is slow and low in elderly, the elimination also is low. However, there are fewer AED pharmacokinetic studies in elderly, especially very old, like 85-year-old or higher. Several AEDs are highly protein bound, as you know, like carbamazepine, phenytoin, valproic acid, and tiagabine. They can be displaced if the serum albumin is low. Changes in protein binding cause misleading measurement of total concentration of highly bound. So if we need to check a level, it is good to check a free level as well as total level of phenytoin and valproic acid, because just getting a total level may be misleading. A lot of these medications go through P450 system, and some of them are inducers like phenytoin, phenobarbital, carbamazepine, and some are inhibitors like valproic acid and topiramate. Let me show you a scatter plot from a study by Cloyd looking at half-life of phenytoin. In elderly, you can see the scatter plot is all over the place, and you can see half-life increasing up to 80 hours. So in elderly, the half-life of phenytoin can be high, can be long. So the medicine is there for long to be active and cause more side effects. We all know that phenytoin is not a linearly metabolized medication, and a slight increase in the medication can sometimes put you into the toxic realm, or similarly dropping a dose by 100 milligrams can put you in a subtherapeutic. But this graph is much more steeper compared to younger adults, and you can see the same thing applies with this tiny increase in elderly that can really put them in the toxic range. Looking at the newer medications, here we have gabapentin, lamotrigine, levetiracetam, oxcarbazepine, pregabalin, tiagabine, topiramate, and zonisamide. Most of them are not going through P450 system. They are less protein bound, and they don't have a high potential to have drug interactions as the older medications. So we tend to prefer these newer medications because they tend to have less interaction to set off the other medication that elderly are on. Just to give you an example, here is a graph of simvastatin level. And when you add carbamazepine to it, the level drops on more than 50%. So on one point, you're trying to save money by adding carbamazepine, but that can really mess up the other medications. Like in this case, simvastatin level can drop by more than 50%. A lot of patients may not volunteer information about herbal medications or their other things they're using. Like grapefruit juice is a potent inhibitor of P450 system. And this graph shows carbamazepine level. And when you add grapefruit juice, the carbamazepine level can go into a toxic range. So that sometimes information is very helpful, and we should ask specifically, proactively. Herbal medications like St. John's wort, people use it and may not declare it, but it's a potent inhibitor of P450, a potent inducer of P450 system, so it can lower the seizure medication levels and that is present. So we have to keep that in mind. Herbs may increase the risk of seizures by the pharmacokinetics, kinetic effects, or also from the intrinsic proconvulsant properties or herbal and drug interactions. A lot of the herbal medications are not monitored by FDA, and they may be contaminated by heavy metals, and that can pose another challenge. So in general, monotherapy is possible for majority of the patients in epilepsy who are elderly. A typical nursing home patient is on 6 to 8 medications. So choose a seizure medication with minimal interactions like levetiracetam, pregabalin, or gabapentin. And looking at the VA cooperative study that gave class 1 evidence for gabapentin to be effective in elderly patients with epilepsy. Always start at low dose and go slow. That principle holds true in elderly as well. Avoid older AEDs with strong inducing effect, like phenytoin, phenobarbital, and carbamazepine, because it can not only induce other medications, carbamazepine can induce its own metabolism. Avoid newer AEDs with established cognitive side effects like topiramate and zonisamide, can both cause cognitive delay. There was a study by Lee where they looked at patients who were on topiramate and zonisamide, not necessarily elderly, but this holds true for elderly as well. 94% of patients experience cognitive viscosity with either drug as an add-on agent. 63% of patients were almost unaware that they were slow. Their caregivers noticed that. So this is alarming that not only it affects their cognition, they are usually unaware of the effect. So we recommend to avoid topiramate and zonisamide in elderly. Oxcarbazepine and tiagabine. Oxcarbazepine can result in hyponatremia, much more commonly in elderly. So it's better to avoid it, or if you're going to use it, then you have to be proactive and check the sodium more commonly. Once they develop hyponatremia, it's usually there to stay. So it's better to switch them to a medicine that does not cause hyponatremia. Tiagabine has been associated with encephalopathy or stupor, and that has been seen with elderly as well. Older AEDs and elderly, inducing medications like phenytoin and carbamazepine, as I said, phenobarbital can result in consequences like behavioral consequences of cognition. Valproic acid can be used in elderly, but very cautiously, because it can cause weight gain and risk of encephalopathy. Phenobarbital can have significant cognitive slowing, depression, and other behavioral consequences. There is an entity which we should discuss, that is valproic-induced Parkinsonism. Patients on chronic valproic acid are more common to have dose-related tremor. In a study by Jamura, like 119 patients, 6 patients who were on chronic valproic acid treatment, developed signs of bradykinesia, rigidity, and postural instability and tremor. So developed Parkinsonism, and on an average, they were on it for at least 1 to 2 years. And the mean dose was 750 milligrams, not a very high dose of valproic acid, but they can develop Parkinsonism. And this is reversible. So if you reduce the VPA dose or withdraw it, the symptoms of Parkinsonism can improve. There was as I said earlier, the VA cooperative study was a study which was primarily done in elderly, and they tested gabapentin, carbamazepine, and lamotrigine for efficacy and tolerability. Efficacy-wise, there was no significant difference between the three medicines, but tolerability was poor for carbamazepine, and there was more dropout in carbamazepine arm compared to lamotrigine and gabapentin. So Brody did a study, multi-center, double-blind trial, 150 elderly patients with new onset epilepsy, comparing lamotrigine and carbamazepine. And seizure-free during the last 16 weeks of treatment. Lamotrigine group did better compared to carbamazepine, and death was significant. The dropout rate was double, almost more than double in carbamazepine arm than the lamotrigine arm. So it said carbamazepine patients were twice as likely to come off medication than one taking lamotrigine. One of the critique in this trial was that it is not a fair comparison between lamotrigine and carbamazepine. Carbamazepine is shorter-acting medicine, and maybe they should compare it with a sustained release carbamazepine. So Sciatre did a study with lamotrigine and sustained release carbamazepine, again multi-center double-blind study, 185 elderly patients. Seizure freedom was quite comparable for both carbamazepine and lamotrigine, maybe slightly higher seizure freedom in carbamazepine group. And dropout rate was 14% in lamotrigine group and still higher in carbamazepine, but their conclusion was that it has comparable efficacy, both lamotrigine and sustained release carbamazepine, and higher seizure-free rate for carbamazepine, but better tolerability for lamotrigine. Let me share a case. Healthy 65-year-old patient with epilepsy has weekly focal impaired awareness seizures, previously called complex partial seizure, despite being on 2 seizure medicines. His ictal focus is in the right anterior temporal region. An MRI showed a low-grade tumor in the right hippocampus. So what to do? The options are neuropace, corpus callosotomy, add prampanel, or vagus nerve stimulation, or selective amygdalohippocampeectomy. So in a patient who is a healthy elderly and have failed the 2 or more seizure medicines, considering surgery as an option is a good idea. So selective amygdalohippocampeectomy was done in this patient, and he remains seizure-free. Not very many studies have been done in elderly for epilepsy surgery. This is from UCLA. They studied their patients who were 60 years of age and refractory patients. They've noticed that out of 12 patients, 11 of them achieved class 1 to class 2, which is good outcome, angle classification in 91% of the patients. And 50% of the patients, like 6 out of 12, were completely seizure-free at 2 years. And the follow-up period was 3 years plus minus 2 years. So their conclusion was the resective surgery for epilepsy in patients aged 60 years or higher is safe and effective. We looked at our own data at Vanderbilt. I used to be there for epilepsy surgery in elderly. We looked at patients who were 60 and above who underwent epilepsy surgery and had resection. We had 24 patients. Median age at surgery was about 62 years, and median epilepsy duration was 36 years, meaning so some of them were patients who had seizure onset at a younger age and then continued in in their old age. We noticed that 79% of them were on more than 2 seizure medication, and 88% had temporal localizations. So, and also 83% of them had MRI abnormalities, and 54% had PET scan abnormality. Selective amygdalohippocamectomy was performed in 54% of these patients, and post-operative complication was about 4%. 50% of the patients had Engel class 1 outcome, meaning they were seizure-free at 2 years, and 75% were seizure-free with a median follow-up to 13 months. So patients who are healthy, elderly, epilepsy surgery can be considered, and it's not a contraindication. However, frail elderly, you may not expose them to epilepsy surgery. And epilepsy surgery in healthy elderly patients may be a good option that prevent them from having seizures, and eventually they can come off the medication if they remain seizure-free for 2 years after the surgery. So in summary, the epilepsy in elderly patients are not rare. Demographics are quite different. And often the seizures are underdiagnosed, seizures are misdiagnosed, and there's a delay in getting to the right diagnosis. Often they are started on older seizure medications. That can cause another problem. So it is better to try seizure medicines that are better tolerable. So we would prefer to use newer seizure medications. As the population is growing older, we are seeing higher incidence of having seizures, and this is going to continue for the next incoming decades. That adds to the healthcare cost. So we need to be vigilant about onset of epilepsy in elderly and treat it accordingly. So I'll stop here and answer any questions if you have.
Thank you, Dr. Arain. That was a very good presentation, very thorough presentation. And if you have any questions, you can either type them into our chat feature or come off mute and ask your questions. We have a few minutes before the next talk, so we would love for you to ask any questions you may have from Dr. Arain. I'm going to look at the chat. Nothing there. It's a shy group this morning, Dr. Arain. Any questions for Dr. Arain?
Can you hear me?
Yes.
Yes, we can hear you.
Okay. Hello. Thank you.
You're
Doctor.
welcome.
I'm a 67-year-old with just determined refractory partial seizures.
Mm-hmm.
And I'm going to be going into a level 4 for evaluation for potentially for surgery. And one thing I wanted to know, and I like the statistics on the success for the selective, what was it, the surgery for the
yes. Mm-hmm.
amygdalohippocampal, anyway. But I was wondering, do those statistics, do they include still staying on medications as well? You understand what I'm saying? How does that relationship work?
Yeah, so they include the patients who stayed on the seizure medicines. In general, whether it's elderly or younger adults, when we do epilepsy surgery, we keep them on seizure medicines for at least 1 to 2 years to let the brain heal, and then we start tapering them off. So eventually some of them can completely come off the medication, but typically from the first year or the second year, they are still on the medication.
Are there any statistics on the success of being able to become less or completely medication free?
Yes, there are long-term studies, which primarily not in elderly, but in younger adults. And people have been followed for 5 years after surgery and 10 years after surgery. So I would say that the seizure recurrence after surgery in those patients can be up to 30% to 35% off the medication. So the rest of them can stay off the medicines.
Okay. Well, I'm going to be evaluated pretty soon, so I don't want to go into the details. But one thing that happened to me was I had seizures since I was a teenager, but they didn't know what they were because that was 50 years ago and just thought I had strange spells and such. But 7 years ago, I started having clusters of hundreds over each year.
Mm-hmm.
And no one has ever, I don't know if they'll ever be able to figure out why that would happen all of a sudden, at about age 60. Is that something you see sometimes?
We do see that at times, and I presented you one of the case who had staring episodes earlier,
right.
and then presented later. We don't know what causes this. Maybe the brain circuitry changes, but it's a million-dollar question why there is a hiatus of several years, several decades, and then the seizures start reappearing.
Right. Well, thank you. I've taken enough of your time, but I really appreciate
all the best for your evaluation. So my message to my colleagues would be to consider your differential diagnosis for elderly patients who present with infusional episodes, that seizure may be a possibility. And with the increasing number of incidents of epilepsy, I think we should always have this back in the mind that epilepsy may be presenting this way.
Great point, Dr. Arain. So I'll make one more call out for questions. I don't see anything in the chat, and I don't see anybody that's come off mute. I don't want to take any more of anybody's time, but we want to thank you, Dr. Arain. That was a very thorough
thank you, Susan.
Presentation, and yes, we'll see you soon.
Sure. See you. Thank you.
Thank you.